Recording. All right, we are recording.
Okay, so we'll talk about perioperative pain management, mechanisms of pain and outcomes, and role of the anesthesiologist. The goals of the talk, we're going to talk about recognition of the biological mechanisms by which pain is sort of mediated. We're going to review postoperative pain management strategies and their relationship to recovery outcomes. We'll review some safety issues related to IV opioids and some non-opioid alternatives and discuss some important components of forming and managing an acute pain service. So why is pain such a difficult thing to manage? I think there are many reasons. One is that pain is subjective, meaning it's difficult to measure it, to put a value on it and compare it, whether it's between various patients or in the same patient over time. Pain arises via multiple mechanisms, and these mechanisms tend to change over the course of the postoperative period. Both pain and interventions that we use to control pain impact the sensorium of the patient. So, for example, pain and pain medications can cause elderly patients to have delirium. And the interventions that we use to control pain similarly can affect the physiologic stability of the patient. The response to pain medication is highly variable between individuals, and for that reason it's rather unpredictable. A dose response is unpredictable. There are opioid conversion tables available, but there are several limitations using them, and I'll talk about that. And one of the most challenging issues is that if we get it wrong in any way, this can lead to serious adverse outcomes. Now, this particular slide is addressing physicians in the United States, but the question is, are we doing a very good job managing pain? Just to put this in perspective, I read a couple of days ago something that quoted that the United States citizenry comprises 4% of the world population, but we consume almost 90% of all the opiates in the world. So this hopefully will put what I'm about to say in some perspective. Studies have shown that the incidence of patients suffering at least moderate or even severe pain is as high as 86%. Poorly treated acute pain has been associated with numerous unwanted outcomes, including, ironically, the development of chronic pain. And there are some very disturbing trends and data relating to patient safety and pain management, both in hospital and outpatient settings. So the endeavor of perioperative pain management has not necessarily been one that has involved anesthesiologists in the past, but it actually provides a wonderful opportunity for anesthesiologists and our specialty to add value and improve the perioperative patient experience and outcome. So I see it as a wonderful opportunity for our specialty to grow. The skill set of the anesthesiologist is ideal for many reasons, including, namely, we can perform regional and neuraxial anesthesia. And this can be done before surgery, or it can be done as a rescue after surgery if surgery becomes more painful than was anticipated. We have a familiarity with the surgical procedures, so are better able to anticipate which patients may need more interventions. We can also initiate certain strategies in the operating room or even before surgery that can be helpful to patients. We'll talk a little bit about that. We know the surgeons and we have a relationship with them, so it's easier to involve them in a team management process. And we are trained to recognize and manage the side effects of excessive opioid administration. So what are we using to manage pain? I think the traditional emphasis has been using opiate medications. One reason they're acutely effective versus most, although not all acute pain. They're very good drugs. And for the most part, there really isn't a ceiling effect. And what that means is with increasing dose, we continue to get increasing analgesia, as opposed to other drugs which may include nonsteroidal anti-inflammatories, acetaminophen, partial agonists, where once you reach a certain dose, you're not going to get any more value analgesically. But this effectiveness comes at a price. And the side effects of opiates are numerous: the suffering, nausea, vomiting, itching, issues relating to safety, hypoventilation, functional issues including urinary retention, decreased GI motility, central nervous system complications including confusion, dysphoria, and even delirium in elderly patients. And there are certain types of pain against which they're only really marginally effective. So another reason that opioid management is difficult is there is literally a tenfold variability between various individual patients in dose versus serum concentration and dose versus analgesic response. So this variability makes the management very challenging and may lead to either inadequate analgesic response or excessive side effects and safety problems. If we use a patient-controlled delivery system like a PCA or PCEA, where the epidural administration is in part controlled by the patient, these systems can in some ways help overcome the influence of this patient variability. And we see this in one way. The evidence for this is that patients using these systems report lower pain scores than patients who get their pain medications on the basis of a protocol. And we also see that patients report greater satisfaction with their care if they are given this this type of system where they can actually control some of the input of the medication. But the question is, are opiates, can they actually make the long-term pain prognosis worse? I think there's some growing evidence that concerns us that this may be true. Hyperalgesia is a term which means disproportionate response to a noxious or painful stimulus. And this has been reported to occur even after very short-term opioid use. And what seems to happen is that patients develop a short-term tolerance, even hours after opioids are administered. And the larger the dose that we give, the larger the tolerance that seems to be created. So for that reason, non-opioid options should always be considered as alternatives or as a means to minimize opioid requirements and side effects. This was a study from back in 2000. It was a large review. And what these authors were trying to decide was how frequently commonplace surgery led to the development of long-term pain. And in this case, defined ongoing pain as pain that persisted more than 12 weeks after the surgery. And even hernia repairs can be as high as a third of the patients can develop neuropathic pain along the incision where surgery took place. And you can see that at the higher end, thoracotomy and limb amputations have as high as 2/3 of these patients were getting developing chronic neuropathic pain as a result of the surgery. So one way to think about this at first is to go back and review how pain is actually brought into the body neurologically, how it's processed. Well, there is one older theory called the gate control theory, which describes the summation of impulses coming into the spinal cord by two different kinds of nerve fibers, A delta and C fibers, which transmit these pain impulses to the spinal cord. Once they're at the spinal cord, there's a modulation of all of these signals, both inhibitory and augmenting modulation of the impulses. And so overall, there's some kind of integrated process occurring at the dorsal horn of the spinal cord. And if we break it down further, we can look at sort of 4 stages of pain processing. From the very periphery, which is transduction, going from where an incision is made or where inflammation takes place in the tissues. And this, one of these processes creates an action potential in a peripheral nerve, whose cell body is going to be in the dorsal root ganglion. That impulse is transmitted, so the second stage called transmission, is transmitted to the spinal cord and up through the central nervous system. And this is going to go via first, second, and third order neurons, whose cell bodies are going to be in the dorsal root ganglion, in the dorsal horn, and the thalamus. Once this happens, there's a modulation that occurs. And what that means is there's an alteration of all of this incoming input along the ascending pathways. And the modulation, again, may involve sort of a muting it down, sort of an inhibitory process, or there can be an amplification of the process, and we'll talk more about that. Finally, the fourth element of pain processing that we don't think about as much as we should is the perceptive part, which involves integration of all of this input into the cortex of the brain and how the patient emotionally understands it and processes it. Ideally, to be effective, we should try to intervene at all 4 of these stages of the process. So just to review again, the nociceptors, which is a term for nerve fibers which transmit painful stimulus. There are various subtypes in the periphery, whether they're from cytokine release, for example, in inflammatory pain, arthritis, infection, etc., hot and cold, or mechanical damage, which we see with surgical incision. And this is a process of transduction best addressed by 2 things. One is non-steroidal anti-inflammatories, and the other is going to be infiltration of local anesthetic. So before a surgeon makes an incision, if he or she infiltrates the skin with local anesthetic, this may actually mitigate quite a bit of this transductive process. The second stage will be transmission, where these impulses are conducted along the nervous system from periphery into the center. And these are best addressed by local anesthetic, whether it's at the peripheral nerves level, at the plexus level, or at an epidural and neuraxial. This is an ideal place for local anesthetic to intervene. The third step, modulation, where all of these inputs are sort of integrated. The common site of action here is the dorsal horn of the spinal cord. And again, some of these modulatory effects are inhibitory, or they are augmenting of these pain signals. Input is created both from the periphery and from descending pathways. And again, the signals sort of are integrated in the spinal cord. So what is the best way to address this area? I think certainly the spinal opioids, and by that we mean neuraxial opioids. That can be via fentanyl or hydromorphone given in a spinal or in an epidural. Use of NMDA antagonists have been shown to be very effective in this modulatory process. And for the most part, we'll talk about ketamine here. And there's also a role for intravenous lidocaine, which I won't talk very much about tonight, although I'm happy to discuss with people afterwards or anytime that you want to talk about intravenous lidocaine. That it seems to be, again, addressing the modulation stage of this pain process. And finally, the perception stage, it involves sort of an affective, subjective component of processing pain. Occurring in the cortex, and the treatments here are systemic opioids, alpha agonists like clonidine, dexmedetomidine, and there is also a role here for the NMDA antagonists. So certainly some overlap, but I think if we think about the pain transduction in these sort of stages, it's helpful. We know that over time, if pain is ongoing, that there's a plasticity and sensitization. And to sort of define that, what we're talking about is that there's ongoing inflammatory mediator release, which activates sort of dormant nociceptors in the periphery. So there were some guys there were certainly some pain fibers that were there, weren't doing anything, but if this inflammatory or injuring process is allowed to perpetuate, some of these guys get into the act that weren't in the act before. This process will increase sensitivity to any kind of stimulus, noxious stimulus, even stimulus that we call sub-threshold, that is, it wouldn't bother an ordinary person. Both central and peripheral sensitization occur, and after that happens, there's an exaggerated response to normal stimulus. And we've seen this by patients who, for example, we put a tourniquet on the arm and they scream. That's a classic example. Postoperative pain will be perceived more intensely, and this whole process characterizes the transition from acute pain to chronic pain. So the pain pathways, just to summarize, are not passive. The injury will actually lead to altered sensitivity. If we consider here, just sort of, we depict the green line as being sort of a normal response to pain in an individual who has not been through any of this. Along the bottom, we'll have increasing stimulus intensity, and at some point in an average person, this person will start perceiving this growing stimulus as painful, and this will go, sort of in a sigmoidal or linear, almost linear manner according to the increase in the pain intensity. Now, after an injury takes place, whether that's nerve injuries or surgery, etc., broken bones, that what we find are that it does not require much stimulus to cause pain. So you can see along the orange line, this is a person who's had sensitization, and that he or she is going to start perceiving very little stimulus as painful. And this is what we would call allodynia, is defined as sub-threshold stimulus is being perceived as painful. And here, as stimulus gets, very modest stimulation will be perceived as pain, which we call hyperalgesia. So how do you address this central sensitization? Is there anything we can do about it? One thing to do is look at how it happens and try to understand what's happening at a receptor level. And one thing that's becoming clear is that the NMDA receptors play an important role in the development of this sensitization. And with that, we see new gene expression that's been demonstrated to occur in as little as an hour after tissue injury. And the intensity of acute pain directly will predict the probability of developing this chronic pain. So if we use a multimodal approach, can we do better? And I think that many of us now are finding that if we do this, patients are requiring less opiate and reporting less pain. And again, just to review, it involves use of local anesthetic at both the incision site and the nerve plexus or neuraxis, as is appropriate for the surgery. Routine use of non-steroidal anti-inflammatories plus or minus acetaminophen. In some cases, intraoperative use of intravenous lidocaine, particularly in cases where neuraxial anesthesia can't be performed, for instance, in patients who have coagulopathy or have refused. Adjuvants, namely neuroleptics, if we think that peripheral nerve injury may occur. And this is going to be true with amputations in patients who've had radiation to the surgical area, and if there are tumors infiltrating nerve plexus. So what specifically do we know about NMDA antagonists? The two that we use are ketamine and magnesium. And it appears that NMDA really does mediate some of the process of central sensitization. And certainly in animals, and there's growing evidence in people, is that very, very low doses of ketamine prevent the development of this central sensitization process. What we do and what some authors have done is to initiate ketamine prior to incision. and to run it during surgery and even after surgery seems to attenuate the central sensitization. And continuing it in the postoperative period has resulted in improved pain scores with less opiate use. And the addition of magnesium, which is also an NMDA antagonist, may have some additive benefit, although this additive benefit may not be evident until some time after surgery. This was one group's study looking at the number of hours after surgery and the cumulative morphine consumption, which is admittedly a surrogate outcome, but showing that if you can continue these medications over time, that the use of both may have some incremental benefit. We've actually initiated a program at UCSF where patients at risk are allowed to have ketamine infusion on a regular floor. We've written order sets, educated the nurses, and this has been very successful in our patients.
Rachel,
So,
Rachel, can I ask you a question?
Yes.
Can you go back to the previous slide?
Yes.
Previous slide, yeah. It would look from this slide that the ketamine plus magnesium results in a higher cumulative morphine sulfate dose consumed.
I have it backwards. I think those are backwards.
Oh,
I apologize.
Okay. So ketamine.
Yeah, I reversed them.
Can you just point
Yeah,
your pointer
yes.
with your cursor?
Yeah, yeah.
Cursor, yeah.
Yeah, this should be here and this should be there. Yeah, yeah, yeah.
فهمتوا يا شباب؟ البنفسجي
Yeah.
لازم يكون تحت والازرق لازم يكون فوق، مقلوبه بس.
Yes. Good point.
Okay.
In fact, here.
Yeah.
Let me fix it. I'm going to do it right now.
Oh, good.
Terrible. I'll do it right now. I hate that.
Oh,
so basically, bottom line, ketamine is good for this. If you add magnesium, you're going to have a little bit of a better, yet better. But even ketamine alone is very very effective for this. So
I just use
we've
half a milligram per kilo.
The one thing we
induction.
Very little. We're using between 1 and 5 micrograms per kilogram per minute. So really, like, the equivalent of about 5 or 10 milligrams an hour.
Yeah.
Very little. Patients now, there's sort of a misperception that using low doses of ketamine like this don't have side effects.
Well,
And the truth is they do. Yeah, and you will see patients who have will report disturbing visual sort of perceptions, and I think the key in using this is to tell people in advance that there's a small chance this can happen, and if it does, we can turn it off or turn it down and things like that. And I have had, I would guess it's about 1 in 5 or 6 patients report that it bothers them. But I always ask.
Yeah.
And turning it down or off has invariably made them happy. So I think there is a certain dogma that this can't happen, and I think that's important to kind of be realistic about it.
When I use ketamine,
yeah,
for especially for prolonged procedures like spine surgery, and I use very little. I use the first hour, maybe I use 5 micrograms per kilo per minute, and then I go down to 2 and quickly go down to 1 microgram per kilo per minute, and continue that until about 1 hour before they stop, especially if it's an older patient.
Yeah.
And one of the good things, unfortunately, we don't have this in Palestine yet, but sometimes they have it at Maqasid Hospital. Ali may have seen somatosensory evoked potentials. And when I use the combination of total intravenous anesthesia of propofol, ketamine, and remifentanil, that increases the amplitude of the somatosensory evoked potentials, and the technicians love it because they can. And it's actually good because then it makes the amplitude higher, then they can detect it better, detect any problems better.
Yeah.
So Yeah, but I use
Earlier,
yeah, I use it even with induction for most cases. I don't know how you use it at UC San Francisco. I use it even for gallbladders, for hernias, for anything.
I'm selective about it. I'll tell you why. I think again, for me, the incidence of problems is higher than I don't think most patients tell you that it bothers them. I think you have to go ask, and that's why I don't use it as routinely as I would. But
But if you give 25 milligrams of ketamine for a man who weighs 80 or 90 kilos
you know
with
what?
induction, and you mix it with the propofol,
It's not